Check, check, sound check, 1, 2, 3, check. A very good morning to respected dignitaries, distinguished speakers, esteemed faculty, and dear participants. It gives us immense pleasure to welcome you all to day one of MPSCON 2026, an international conference hosted at Dr. Chandrama Dayanand Sagar Institute of Medical Education and Research under Dayanand Sagar University, Bangalore. Organized by the Department of Pharmacology in association with the Department of Physiology and in collaboration with the Medical Pharmacologists Society. This conference stands as a prestigious academic platform bringing together experts, researchers, clinicians, and students across the country and beyond. I'm Sanya, and I'm honored to be your host for this grand scientific gathering. The theme of this year's conference is Pharmacology 4.0, Smart Drugs, Smart Data, and Smart Decisions that reflects and evolves around the landscape of pharmacology, where innovation, artificial intelligence, and data driven medicines are shaping the future of healthcare. We had a wonderful pre-conference workshop and which was based on career conclave, systematic review, meta-analysis and research methodology. Over the next 2 days, this conference will serve as a vibrant platform for scientific exchange and interdisciplinary collaborations, presentations of cutting-edge research and innovations, engagement with renowned academicians and industry experts, skill development through discussions, presentations, and interactive sessions. A new development in this conference is the MOU signing, research grant, quiz competition, lifetime achievement award, excellence award, and MPSCON 2026 is not just a conference, it is a confluence of knowledge, innovation, and professional excellence aimed at advancing pharmacology, education, research, and clinical practice. We are deeply honored by the presence of our esteemed dignitaries, respected chairpersons, invited speakers, and enthusiastic participants who have gathered here to contribute to this academic excellence and academic celebration. Before we begin the scientific proceedings, we would like to gratefully acknowledge our sponsors and supporting organizations whose generous support has contributed immensely and has contributed to this academic celebration, the success of MPSCON 2026. We sincerely thank our platinum sponsors, which is Himalayan Wellness, Medibay and IQ Training, gold sponsors, eClinical Works, exhibitors, JP, Shri World Book Publishers, Zedas, Lateral, and CBS Publishers. Supporting organizations, IMA, DSU Institutions, AIMS, Guwahati, Health Technology Assessment in India, Department of Health Research, and academic collaborators for the valuable partnership and encouragement. We extend our heartfelt gratitude to all our sponsors, exhibitors, collaborators, and supporters for being an integral part of this prestigious conference. With this, let us begin day one of MPSCON 2026 with great enthusiasm and academic spirit. We shall now begin with a scientific session 1. The scientific session 1 is themed as Core Pharmacology and Transactional Science. To chair this segment, may I invite our respected chairpersons, Dr. Sachin Manocha, Professor and Head, Amrita School of Medicine, Faridabad, and Dr. Nalini GK. Pardon, we have a small correction. Once again, pardon me for the error. We have Dr. Sachin Dhanananda Adiga MN, Professor and HOD, Department of Pharmacology, AIMSR Chittoor, Member Secretary of IEC. Now I'd like to request the organizing committee to kindly introduce the chairpersons. Thank you. I now request.
Good morning all. Myself Dr. Anusha, Associate Professor, Department of Pharmacology. It's my privilege to introduce Dr. Sachin Manocha, Professor, Head of the Department Pharmacology, Amrita School of Medicine, Faridabad, who is a renowned academician and pharmacologist with 18 years of experience in medical teaching, clinical research and regulatory affairs. Actively involved in phase 3, phase 4 clinical trials, ethics committees and postgraduate research guidance at reputed institutions. Published researchers and invited speakers, examiners at several national and international conferences and university.
Good morning, one and all. It's my privilege. I am Dr. Chaitra from Department of Physiology to introduce Dr. Sachidananda Adiga, MN, Professor and HOD, Department of Pharmacology, AIMSR Chittoor, Member Secretary of IEC AIMSR and Member of Curriculum Committee. Sir has guided PhD scholars and published 72 papers in national and international journals and has held leadership roles in ethics committee and institutional scientific committees.
I would now request the chairperson, Dr. Sachin Manocha, to kindly take over and to introduce Dr. Siddhartha Datta, Assistant Professor of Pharmacology, AIIMS Rajkot, who will be speaking on targeted therapeutics, small molecules versus biologics, and conduct this session. Thank you, sir.
Good morning, all. At the outset, I'd like to congratulate Dr. Shivamurthy and all the organizers for organizing and conducting this great conference. Dr. Siddharth Datta is going to give a talk on small molecules versus biologics in modern therapeutics. Dr. Siddharth has experience of 8 years post-MD in teaching and preclinical research. He has received President NBEMS Gold Medal for highest academic excellence nationally in DNB exams, has a research credit of more than 100 publications, national and international journals, has research interest in research, pharmacovigilance, meta-analysis, emerging therapeutics, particularly in chronic disease management. Received National Award for Excellence in Research in MPSCON24 and 25, and he has been listed among Stanford University's world's top 2% scientists, recognizing significant research impact and citations. So I welcome Dr. Siddharth Datta to take over and start his presentation.
Good morning.
Yeah, Dr. Siddharth, you can start.
Are the slides visible?
Yes, please. You can put it in slideshow and start.
Good morning, everyone. Respected chairperson, dignitaries, and faculty members. At this outset, I would like to thank MPS and Dr. Shivmurthy sir for giving me this opportunity. I'm Dr. Siddharth Datta, Associate Professor at IIMS Rajkot, and I welcome you all to the first session on targeted therapeutics, small molecules versus biologics. Now, before I start, there is a disclaimer. The views, opinions, or conclusions that has been presented in the particular presentation are completely mine, and it does not represent the standing or opinion of MPS or AIMS Rajkot. Now, moving on to the targeted therapeutics, these are medications that are designed precisely to modulate the key molecular pathways involved in a particular disease. Now, to understand, these are molecules that are unprecedentedly, they have a understanding of molecular biology, genomics, and signaling pathway. And the core of this particular targeted medicine is dominated by two pharmacological modalities, small molecules and biologics. So we are going to look at them, their discovery and development methods, the regulatory guidelines they follow. Followed by that, we'll be looking at the kinetics, dynamics, safety profile, and the therapeutic areas where they are being used and indications. And then the recent advances and future directions in this particular targeted therapeutics. And finally, the conclusion and key takeaways. Now, moving on to the topic directly, talking about small molecules, as the name suggests, these are smaller in nature, hence they have a very low molecular weight, less than 1 kilodalton, and they are lipophilic in nature. Because of their lipophilicity, they can easily cross through the biological membranes and they get into the cell directly to have their action on the receptors and targeted enzymes. On the other hand, they are chemically synthesized, they are generally stable and have a high risk of off-target effects. Almost 90% of the approved drugs are biologics in nature. Now you have to understand these small molecules can pan from your aspirin, atorvastatin, omeprazole, or your phosphodiesterase inhibitor, ACE inhibitors. These are all small molecules. But when we talk of targeted therapeutics, they are basically the tyrosine kinase inhibitor, BTK inhibitor, ALK inhibitor, VEGF inhibitors like sunitinib, sorafenib, all those drugs. It is a numerous drugs we will discuss. Now coming on to the biologics, they are basically protein, larger in size, monoclonal antibodies, peptides and all the molecules, and the size is almost more than 10,000 kilodalton, and they are hydrophilic in nature. Because of the two issues, hydrophilicity and large size, they do not cross the biological membranes and have their effect on the cellular surface itself. They require parenteral administration, and strict cold chain maintenance is required for their use. Now moving on to the drug discovery and development method, the small molecule entity has a defined chemical synthesis procedure. So that is why there is a high rate of batch to batch reproducibility, and they are generally stable at room temperature. And the development cost spans around $1 billion. Whereas when we talk of biologics, they are completely different. They are developed in a living material, mostly Chinese hamster ovarian cells, mammalian cells, or it can be also developed from the microbial cultures like E. coli or yeast cell. After the protein is extracted, they are processed for any impurities or deformity, and followed by that, their structural microheterogeneity is removed by post-translational modification by the methods like glycosylation, fucosylation, or even deamidation, oxidation, reduction. When the complete antibody or the biologics is completely made, they are to be maintained under strict cold chain storage from 2 to 8 degrees centigrade and strict pH control. And the cost of development is around 3 times as compared to the small molecules. Now moving on to the regulatory guidelines which they follow, the small molecules, they follow Food, Drug and Cosmetic Act, and they are filed through new drug application. They get around 5 years of exclusivity, followed by which exact chemical replicas are being generated and they are called as generics, which we know in the market. On the other hand, the biologics, they follow Public Health Service Act, and they come under biologic licensing application. They are applied through, and then they get a 12 years of exclusivity, followed by which the follow-on biologics will come to the market is known as biosimilars. They are not exactly the same as the reference biologic, but they are similar to it, similar in terms of efficacy, safety, purity, and even immunogenicity studies. So that is why they are called as biosimilars. Now, with that, we move on to the pharmacokinetics. Speaking about pharmacokinetics, these molecules, small molecules, they are smaller in size and are lipophilic in nature. Hence, they can easily pass through the biological membranes and have a high volume of distribution. They are metabolized by the liver through CYP-P450 enzymes and excreted by either biliary route or kidney. Whereas when we talk of biologics, because of their large size and hydrophilic nature, they do not cross the membranes and they stay back in the central compartment. They have their effect at the site of action and they are degraded or metabolized by proteolysis. Followed by that, the reticuloendothelial cells which are present, they excrete the rest of the part. Now we'll dig into more into the metabolic rate and elimination profile of these two molecules. As you see, in the small molecules, because they are being metabolized by the liver primarily, we also know CYP-P450 is also responsible for metabolism of majority of the other drugs, normal drugs which we give. So any concomitant drug therapy which is given along with the small molecules, if they are being metabolized by the same type of enzymes, there is a high risk of drug-drug interaction with the small molecule inhibitors. Whereas when we talk of biologics, these biologics are taken up by the cell and it gets into the acidic lysosome, it leads to proteolysis and the amino acids are used by the cell for their own good use. On the other hand, there is a separate pathway which functions that is known as FcRn salvage pathway. Now, what is the full form? It is neonatal Fc receptor. What is the function of this receptor? This receptor binds to the Fc portion of the antibodies of the biologics. Now, what happens? What is the function? After binding, it is preventing the proteolysis or degradation of this biologics from the acidic lysosomes. After prevention and rescue, it is leaving or releasing the particular enzyme into the cellular surface and again it is going into the blood. Now what is happening? There is a complete recycling of the biologics again and again, and this repeated recycling of the antibody in the body is increasing the terminal T half, your T half. Now I give an example of cetuximab here. Cetuximab is a EGFR, epidermal growth factor receptor monoclonal antibody, and the expected T half of cetuximab is only 4 days. But when we see the exact T half of the molecule, the terminal T half or the clinical T half of the molecule, the drug is given once in 2 weeks. That means twice monthly it is given, and it is because of this salvage pathway. And this is the reason for extended half-life of the biologics. Now, based on that, coming on to the dosing curves, as the small molecules, the effect is closely tied with the plasma levels. So they are given as per the T half, either once or twice daily. Whereas because of the long T half of biologics, they are given once weekly or even once in 28 days or once monthly or even 3 monthly or 6 monthly. Now moving on to the mechanism of action, dynamics. Now this is the small molecule which we have discovered. Let's say I'll take example of any tyrosine kinase inhibitor like geftinib or orlotinib, and this molecule was developed against a particular Janus kinase which was there in the target A. Now how this molecule function? They are actually similar to there is a structural similarity with the ATP. So they are competitive inhibitor with the ATP. They are binding to the active site of ATP so that the ATP cannot bind to the active site and cannot phosphorylate. Hence the downstream pathway are blocked. Now because of the structural similarity to ATP, it is also binding to multiple other kinases. Now what is happening at last? Because of this, multiple kinases are being blocked at the same time, and the numerous cytokine pathways are blocked. So multiple number of cytokines can be blocked at a time. On the other hand, if you look at the toxicity profile, because of the off-target effects, the risk of cytotoxicity is more with the small molecules. In the biologics, we'll see they are immune recruiter in nature. We'll see in detail. Now moving on to the detailed mechanism of small molecule inhibitor. We have seen these kinds of videos where these are called as dominoes. These stacks are called as dominoes, and if you touch one of them, there is a series of chain reaction where a single event triggers the sequence of similar type of events and causes a cumulative impact. Now, let's say this cytokine is a TNF alpha or IL-6 and has bound to a particular receptor, TNF alpha receptor. And because of that, the second messenger pathway like JAK and STAT was being activated, and there was a sequence of events leading to a decrease in the IL-6 or TNF alpha. Now, if I give a blocker like TNF alpha blocker, adalimumab or golimumab or infliximab, anything, certolizumab, it will only block the synthesis of TNF alpha through this route. Whereas, if I can block a JAK stat, I give a JAK stat inhibitor, because of the non-selectivity, it will block multiple pathways, multiple JAK stat kinases, and it will lead to decreased synthesis of multiple cytokines at a time. And it has been seen as almost 60 different cytokines can be blocked by one single JAK-STAT kinase inhibitor. Now coming to the mechanism of action of biologics, they actually recruit the host immune system to eliminate the target. And they do it by two mechanisms like antibody-dependent cellular type cytotoxicity, where it recruits the natural killer cells and macrophages so that they can release the lytic granules and damage the tumor cell. On the other hand, it can also recruit the complement dependent cytotoxicity through formation of membrane attack complex. Membrane attack complex forms on the tumor cell, it creates a pore and damages the tumor cell. Now we come to the safety profile and tolerability profile of these two entities. First, the small molecules, as we have discussed through the mechanism, because of the off-target and non-target effects, the risk of cytotoxicity is more with the small molecules. Now, the commonest side effect which we see with the small molecule inhibitors are dermatological rashes, diarrhea, then LFT, increase in the LFT, QT prolongation, pulmonary edema, then left ventricular hypertrophy. These are some common side effects. On the other hand, the risk of systemic allergic reactions are lesser. Talking about biologics, these are actually molecules that are foreign protein in nature, and because of that, there is development of anti-drug antibodies. Now, these antibodies are actually neutralizing antibody, and because of that, on repeated administration, there is a decreased efficacy of these products. The second point is acute reaction. Because they are foreign antibody protein, when being injected, there is risk of hypersensitivity, and that can present as a infusion related reaction or can be even life threatening cytokine release syndromes. On the the third point is chronic risk. Chronic risk is there because the disease in which these drugs are given are mostly chronic diseases. Now, because of the immunosuppression, what happens in the long term, there is a risk of reactivation of the diseases like latent TB, hepatitis B and C, and even opportunistic reactions like HIV and even candida can occur in these patients. So we have to keep an eye and monitor the patients regularly. Now, with that understanding, we move on to the real life scenario. I have taken example of rheumatoid arthritis here. So the first line therapy for rheumatoid arthritis is methotrexate, and any case of resistance or failure, we move on to any kind of biologics or JAK inhibitor. Biologics can be TNF alpha or IL-6, TNF alpha any adalimumab or golimumab, or IL-6 inhibitor like tocilizumab, whereas the JAK inhibitors like baricitinib, tofacitinib, upadacitinib can be given. And this data has been taken from the meta-analysis, and it has shown that this JAK inhibitor has a better disease remission score as compared to the biologics. The same thing has been depicted here. If you see here, the JAK inhibitors, they have a high rate of remission rates and low rate of disease activity, and the vast pain score is also lesser with the JAK inhibitor as compared to the biologics. And this is because of blocking of numerous kinases and subsequent downstream pathway, and there is more complete blocking of the inflammatory pathway with the small molecule inhibitor as compared to the biologics. Now the same example has been taken from oncology field. Now this is an EGFR molecule, epidermal growth factor receptor, which is important in the field of non-small cell carcinoma and other colonic carcinoma. And the drug, the monoclonal antibody which attaches to it is cetuximab. On the other hand, the intracellular domain, which is a Janus kinase domain, is blocked by small molecules like erlotinib, geptinib, and other molecules. Now, how we can use this particular thing that, let's say there is a mutation to the particular monoclonal antibody like cetuximab. Because of the conformational change, this cetuximab is not able to bind to the uh, outer receptor. In those cases, in cases of resistance, this jectinib or erlotinib, the kinase inhibitor, can be given to overcome the resistance and have it effect. There are researches and meta-analysis that has proven that even concomitant administration of both the drugs can lead to additional effect in these cases. Now, these are the therapeutic areas and domains where these drugs are being used, and majority of the drugs have been developed in the field of oncology and immunology. I've taken one examples from there, like imatinib. It is a tyrosine kinase inhibitor for CML, targeting BCR-ABL gene. Similarly, protein and trastuzumab. All of us, we know that this is a HER2 new receptor monoclonal antibody. Similarly, in immunology, tofacitinib, which is a JAK kinase inhibitor, can be given in psoriasis, plaque psoriasis, and alopecia areata, even in vitiligo. And similarly, this adalimumab is a monoclonal antibody against TNF alpha. You have other golimumab, certolizumab can be given. In infectious disease also, molecules like sofosbuvir, which is a HCV NS5P inhibitor, are given. On the other hand, in infectious diseases, monoclonal antibody like palivizumab is against the Rao sarcoma virus fusion protein. In cardiology, HMG-CoA reductase inhibitor like atorvastatin, rosuvastatin are the small molecules, whereas PCSK9 inhibitors like monoclonal antibodies like alirocumab, bococizumab, evolocumab are the monoclonal antibodies that can be given. With that, we move on to the recent advances, and the first recent advances is on the small molecule inhibitors, and the name
Dr.
of the
Siddharth,
molecule.
your
Yes,
time
sir?
is getting over. Can you please wind up?
Sure, sir. The first molecule is PROTAC, which is proteolysis targeting chimeras. And if you see, first we have to understand why we need advances in the targeted therapy too. So if you see here, this molecule is attached to an active site here and having its effect. But there are also some of the molecule, almost 3000 identified molecules where there is no active site. Now the problem is, if there is no active site, we do not have any drug against it. The second thing is the proteasome. This is a natural disposal mechanism of the cell where it eliminates the misfolded and damaged protein. Now, in these cases, what happens? The disease-causing protein, they evade this proteasome shredder. Now, we have two problems. We do not have a drug against those proteins. On the other hand, the proteasome is also not destroying the protein. So, the protein gets accumulated and causes a chronic disease. So to overcome this problem, this PROTAC molecule was developed, and if you see here, it is a tripartite structure. It has three parts. There are two ligands here. One is binding to the protein of interest. The other one is binding to a ubiquitin ligase. And the third part is the linker. What is the function of the linker? Linker pulls the two ligand, or it pulls the two ligand to the close proximity when it is needed. Now coming into the complete mechanism, if you see here, the protein of interest is attached to the protein ligand and E3 ligase is attached. Followed by that, because of close proximity, this E3 ligand transfers the ubiquitin to the protein of interest. And once this is getting ubiquinated, it is being taken up by the proteasome and it is degraded. And this particular PROTAC molecule is released. Now, a single molecule can catalyze the destruction of multiple proteins, hence can be used again and again with profound efficacy and remarkably low doses. Now, these are the examples of PROTAC, like bavdegalutamide. We have studied about nilutamide, bicalutamide, androgen receptor antagonist. Similarly, we have vepdegestrant, which is an estrogen receptor antagonist, and like fulvestrant, SERD, and there are other molecules, named molecules against the B cell and T cell malignancies. Coming to the other advantages of these molecules, PROTACs. Yes, sir?
Kindly wind up, please.
Yes, only 2 slides, sir. It can be also used in the cases of resistance, where active site is not needed. On the other hand, because of the intramolecular folding, the polar group, they come inside and they can easily pass through even the blood-brain barrier. These are some of the other targets against which PROTAC molecules are being developed, and the final 3 precision medicines which are being developed are antibody drug conjugate, where a particular antibody is attached to a particular toxin and it is delivered to a cell so that it can directly kill the cell. It is ventuximab vedotin. There are almost 100 more molecules which are under development. Next one is bispecific antibodies. The name itself is suggesting it is binding to the tumor cell as well as to the T cell. It is getting the T cell closer to the your target cell so that it can directly kill it. And the third one is chimeric T cell receptors, where the T cells are being reprogrammed with a hunting receptor and they are reinfused to kill the tumor cells. So these are some of the molecules which are come up, and they are recent advances. And to conclude, I'd like to conclude the session with the comparison of the two entities which we have discussed. Talking about small molecules, they are smaller in nature, low complexity. Biologics are larger in nature with high complexity. Manufacturing is easier in small molecules, whereas it needs a huge amount of precision for biologics. Kinetics, they are easy, they can be given by enteral route and high volume of distribution, whereas this is to be given only through the parenteral route because of the protein nature. Dynamics, they act on the intracellular targets and have a low rate of specificity, whereas these are very specific, biologics are very specific on the extracellular targets. Safety, high rates of chemical toxicity is there with the small molecules, but that is not with the biologics, but there is risk of immunogenicity. And regulations, it is around 5 years of exclusivity they get. After that, it is generics which is in the market, whereas it is 12 years of exclusivity and the follow-on drug is known as biosimilar. With that, I would like to conclude, and these are my references. Thank you.
Thank you, Dr. Siddharth, for this enlightening talk on small molecules and biologics in modern therapeutics. I think we'll have just enough time for one or two questions, maybe, if anybody has in the audience.
Yeah, very interesting slides, Dr. Siddharth. I congratulate your effort. But by and large, we are using both small molecules as well as biologics. But which one has more promising in future? Because you are expert now, you can tell.
Give example of any dermatological diseases like atopic dermatitis or psoriasis or something. We prefer giving small molecule at first, but the problem with the small molecule is time what happens if there is increase in the toxicity, we move on to the biologics. Why we do not prefer biologics at first go? It is because of the cost. 24,000 rupees, 24 to 30,000 rupees. So that is a big problem for Indian scenario. Biologics are more specific to a particular disease, and they have a low risk of side effects. And now with the generation of your human monoclonal antibody, the risk of immune reactions are also lesser. So it basically depends upon the adherence of the patient and the cost scenario.
Yeah, very nice. I was also going to ask you the same question in terms of efficacy and safety. What percentage of these therapeutics are going to be, manufactured and being used in our country vis-a-vis the rest of the world?
So we are using small molecules at a large this thing, because I've seen the OPDs, they are writing the small molecules very commonly in the dermatological and immunological diseases. But monoclonal antibodies is difficult to procure. One shot for 24,000, 30,000 rupees is difficult for Indian scenario.
Yeah. Okay, thank you, Doctor. Thank you so much for enlightening our audience and youngsters with this, upcoming topic in drug discovery and development. Thank you so much.
Thank you.
We can have a round of applause for the eminent scientist.
Thank you so much. Thank you, everyone. Thank you for that insightful presentation once again. We appreciate the valuable contribution of the speaker and the guidance of a chairperson. Thank you. We now proceed to our next presentation. I now request the chairperson, Dr. Sachidananda Adiga, to kindly take over the proceedings, introduce Dr. Shruti Singh, Associate Professor of Pharmacology, AIMS Patna, who will be speaking on advanced drug delivery systems, nanocarriers, antibody drug conjugates, and conduct this session. Thank you so much.
Thank you very much. It gives me immense pleasure in inviting Dr. Shruti Singh. She is Associate Professor in Pharmacology, AIMS Patna. She has got 12 years, more than 12 years of experience in UG and PG medical education. She is a FIMER fellow, and her keen interest is medical education in teaching, learning, as well as assessment method. And she is currently pursuing a master's in health professional education from King George Medical University. And also she has got a special training in Harvard. She is a TEDx speaker, and also she is holding a multiple responsibility in the institute, like she is member secretary of Institutional Ethics Committee, and also regulatory review of research protocols. She has got more than 60 articles to her credit, having a H index of more than 14 and a I-10 index of 30 in the field of pharmacology, medical education, AI in healthcare, and rational drug use. She is an active contributor to CBME curriculum, AdCom, faculty development, and innovative teaching and learning strategies. She is a known figure in the field of various conferences, workshops, and especially faculty development programs held across India. She is interested in integrating technology, reflective learning, as well as competency-based medical education. Now, it gives me immense pleasure in handing over the mic to Madam. She will be delivering her given topic today. Over to you, ma'am.
Thank you so much for that kind introduction, sir. And at the outset, I'd like to give a great shout out to the organizers of this fantastic conference at a beautiful location. It's been wonderful attending the pre-conference workshop yesterday. And thank you to Shivraman sir extensively for Shivmurthy sir having invited me for this particular topic. So without wasting a lot of time, I see a lot of dignitaries sitting in front of me. Gitanjali ma'am is there, Bishwas sir is there. I feel a little intimidated speaking in front of such luminaries of pharmacology, but still I'll try my best. So the topic that was given to me was advanced drug delivery systems, and particularly nanocarriers and antibody drug conjugates. And my previous speaker has set the bar high, but what I'm going to do is trying to keep it simple, a little simple, because I see a lot of students sitting in the hall in front of me. Let's try and understand together and see where these two particular drug delivery systems, what they are about and where we are going with them. So, when we administer a drug, most of us sitting here as pharmacologists, one of the things that we always try to do is to achieve maximum concentration at our target site with a good amount of bioavailability, with limited exposure to tissues that gives us a good therapeutic index also, good bioavailability. But as you can see, there are, lots of challenges with regular drug delivery system. There is low concentration at, various sites, and the sites where we do require them, we don't get enough exposure, bioavailability, and enough duration of action. So now, when you talk about failures, usually our failures are not therapeutic failures. Many a times they are failures of delivery at the right place. So when we are evaluating any kind of drug development or delivery system, there are 3-4 questions that we need to ask ourselves. The first is about exposure. Where exactly is the concentration reaching? Is it just in the plasma, or is it actually reaching where it is supposed to reach? Then we need to ask about distribution. What is the biodistribution of the molecule? What amount is reaching the tissue and what amount is, reaching other tissues? What is the engagement? To what extent is the molecule actively engaging with the target? Whatever molecule we are giving, is it actually going and engaging with the target? And last but not the least, the therapeutic index. When we are trying to increase the efficacy, are we also thereby increasing the toxicity? So when we talk about traditional drug delivery systems, it has always been a problem that a lot of our formulations fail for a variety of reasons. There are a variety of reasons. One of them may be solubility. Some of them may be because of rapid degradation, and that degradation can have multiple causes, enzymatic degradation being one of them. Then conventional drug delivery, as I just said, have a lot of conventional toxicity associated with them on target as well as off target. And we will talk about these two specific entities when we are talking about ADCs or antibody-linked drug conjugates. What is on target and what is off target toxicity? And finally, there is always the problem of non-specific distribution. So how have we been trying to handle that? And we are all aware of the presence of advanced drug delivery systems. This is nothing new. But some small, tweaks have consistently been done to them. When you talk about biologics, consistently we are seeing new tweaks being done to them. CAR T-cell therapy is there, PROTAC-based therapies there. A lot of things are now coming up, which are now trying to give us a certain desirable profile. We are not very successful, but still we have reached a certain extent, where we are now able to get a certain amount of targeted efficiency. We are now able to get better bioavailability. We are also able to get controlled release. If you remember, we did have depot formulations from many decades where we were able to get controlled release. But nowadays, even with advanced drug delivery system, even when we talk about nanocarriers, by virtue of their very chemical nature, by virtue of their formulation itself, we are able to achieve depot formulations and longer, long release formulations as well. And just one thing I'd like to point out at this point, that the formulation of any molecule at this stage is not just a formulation parameter now. The formulation itself has now started contributing to the pharmacokinetics. It has now started giving us desirable properties, and we will see to a large extent we have been able to establish that with nanocarriers. So I'm sure we know all this, but this is just a summary for us where I'd like to mention some of the advanced drug delivery systems that we have today. And this is a very small list, mind you. There's a whole lot of new things that is happening around the world, and even within the classes, this is just a very small list that I have mentioned here. So if you see, we have nanocarrier-based systems, and a lot of these we may have already heard earlier. We have heard about liposomes, we've heard about dendrimers, we've all read them in our undergraduate, postgraduate days. Basically, what are they trying to do? If you reflect back to what I talked about earlier, we did talk about targeted delivery. We did talk about improving the bioavailability. So nanocarrier systems, to a certain extent, are definitely able to improve and give us targeted efficiency. Then you have a whole lot of, another category known as targeted drug delivery systems, particularly the antibody-linked drug conjugates. And subsequently, we'll talk a little more about them. You have controlled sustained release systems such as depot formulations. You have osmotic pumps, hydrogels, implants. A lot of systems are existing that are able to give us controlled release. Then you have certain very smart drugs. They are very smart in the sense that they are stimuli responsive. And at the right stimuli, they are able to deliver the payload or the drug. Now, this stimuli can be anything, and it can be very, very site-specific. It can be a specific pH, it can be a specific temperature, it can be light, it can be the microenvironment, it can be anything. So thereby, they have been named as smart drugs. Then we have our whole lot of biological delivery systems, and they are all, the viral vectors, exosomes, they all come under advanced drug delivery systems. Of course, the transdermal drug delivery systems, where we have consistently been using microsomal patches from a very long time. Now, what exactly are all these systems doing? What have they been able to give us over a very long period of time, bringing us nearer to a better therapeutic index? So they have been able to give us better targeting. They have been able to give us controlled release, improved bioavailability, and various other desirable properties. So these are just examples that I had put down here. If you talk about liposomes, we have been reading about liposomal doxorubicin. We have lipid nanoparticles that were used extensively during COVID. You have micelles, polymeric nanoparticles. Polymeric nanoparticles give us a beautiful landscape of controlled drug release. Then antibody drug conjugates, Dr. Siddharth talked about that also. We have another very wonderful drug which is nearing approval currently. Biological delivery systems, like I told you, we have Abraxane, which is being used extensively in cancer chemotherapeutics currently. mRNA-based delivery systems, exosomes are there. And of course, the stimuli-based or smart systems. Now, like I said, what my topic particularly for today was about nanocarriers and antibody drug conjugates. So let's talk, look a little deeper into what exactly nanocarriers. And like I told you, nanocarriers have been able to give us a lot of improved therapeutic index by virtue of certain changes that have been integrated into the formulation itself. One of the first things that they have been able to give us is enhanced, circulation time, prolonged circulation, and better bioavailability. Biodistribution has improved. And if you see, the changes that have been integrated in nanocarrier-based systems have been multifaceted in size, in charge, in surface chemistry. And pegylation, remarkably, has been able to give us a lot of properties that we were always looking for. Even the local free drug concentration available at the target site, because there is a very important thing that we have to look at when we are talking about drug delivery system, and that is carrier stability versus payload deposition. If your payload is deposited early, then there is a very high possibility, which often happens with a lot of drug delivery systems, such as your antibody drug conjugates and even with nanocarriers, because at the end of the day, we are always looking for targeted efficiency. So to what extent are nanocarriers or any of these advanced drug delivery systems able to give us the payload at the targeted site? Now, that is the question. So with nanocarriers, that to a large extent we have been able to achieve. And now that we are talking about targeted drug delivery, we want our drugs to reach and be able to penetrate the barriers that surround a large number of tissues, or a large number, specifically if you talk about tumor, targeted chemotherapeutics. So any formulation or any advanced drug delivery system should be able to penetrate the barrier. And by virtue of the nature of the tumor, many of them are very leaky and they are able to allow a lot of molecules. But then, like I said, the amount of integration that is there between the linker and the payload needs to have a very fine balance into how much stability is there and how much they are able to deliver the payload. So that is increasingly, that is why I said that a lot of formulations are now just no longer formulations questions. A lot of formulations have now become pharmacokinetic related questions. So there are many type of nanocarriers as well. Like I said earlier, we will not dwell upon this slide a lot. You have your liposomes, which are phospholipid bilayers. There's an aqueous core inside. This is just for the students who are sitting here. And then we have the bilipid layer where the drug, so we can have both kinds of drugs here. We can have drugs that are lipophilic as well as hydrophilic. Then you have the polymeric nanoparticles, which are coated by certain biodegradable polymers, which are able to give a controlled release. Then we have the lipid nanoparticles, the LNPs, which have come up in a very, very big way to facilitate mRNA-based therapeutics. And like I said, the last is the stimuli-based systems, which function on the basis of the specific stimuli they get, which can be anything. It can be, like I said, pH, temperature, it can be anything. And I'd like to explain this with an example here. The example that I've put forward here for you is pegylated doxorubicin. So on the left, if you see, is conventional liposomal formulations, and because the surface is unmodified, they undergo rapid degradation by a process which is known as opsonization, which makes them then very susceptible to being taken up by the reticuloendothelial system. And we know what happens then. Bioavailability decreases. The entire spectrum that we are talking about of enhanced efficiency, it is all lost at that point of time. If you see, the central panel shows the pegylation of the molecule, and this pegylation, by a very simple and beautiful mechanism, is able to give a stealth barrier. This stealth barrier then makes that particular molecule resistant to a lot of degradation mechanisms that are out there. And mind you, there is not just one. A lot of things are out there which are able to degrade the main molecule, and this thereby increases the area under curve, the bioavailability of the molecule at the target site. And very importantly, this demonstrates that nanocarrier pharmacology, like I said again, has now, the formulation in itself has become a determinant of the pharmacokinetics. But what are the problems? If everything is so nice, if, with nanocarriers, we are getting what we wanted at all points of time, but there is this pharmacological hitch that we always talk about. You don't get the good effects without the bad effects, and some disadvantages, of course. So they are known as translation pitfalls. One of the things that need to be looked at is we are saying that there is an enhanced permeability and retention effect with nanocarrier-based systems. That is what we are claiming. But this enhanced permeability and retention effect with the entire nanocarrier-based system is very, very heterogeneous, and it is very, very variable. The variability is, drug dependent. The variability is the disease dependent. So trials have shown that what is very clear pharmacologically, in real world, it usually doesn't. So there's a clear translation gap. We cannot just be looking at pharmacokinetic endpoints. We do really need to appreciate how these pharmacokinetic endpoints are translating to clinical endpoints. So the EPR effect shows great variability. We were assuming that the reticuloendothelial system uptake would be less because we have made certain changes, but then how far we have been able to reach there is still, there's still a very long way to go. The other very big problem is of scale up and manufacturing. So if you even change a little bit of the particle size and the formulation, as is a fact with biologics, a lot of pharmacokinetics will now change. So the reproducibility and the kind of repeatability of the endpoints that we desire is not always attained, and then there is always the problem of the assay gap. What exactly are we assaying? Is pharmacokinetics alone, or do we really need to look at tissue exposure and organ partitioning? So that is why, where are we going with this? What exactly are we doing to, what is the recent evidence telling us? So earlier, nanoparticle-based questions, nanoparticle-based research was heavily materials focused. What material are we using? What pharmacokinetic, and how is the morphology of the material that we are using? How is the particle being synthesized? But now, the questions that are being asked about these molecules have shifted. And how have they shifted? Now the questions that we are asking is, how are these nanoparticles affecting pharmacokinetics? How are they affecting biodistribution? How are they, is the translation gap being adequately reduced, addressed? And if you see, the second important shift has been to look at not just pharmacokinetic endpoints, but really, really important clinically meaningful endpoints, and thereby the importance of real-world evidence coming from various types of observational and interventional phase 4 studies that are going, particularly in context to these new molecules. So in other words, the field is gradually moving from, can nanoparticles be engineered? Can they be formulated? To the question that, can we actually reproducibly achieve clinically useful exposure and outcomes? So there's a slight shift in the questions. So then moving on to nanocarrier, and then to the next type of drug delivery system, which is nanocarrier based to precision therapeutics, absolutely targeted precision-based molecules, whereby we can now start to look at antibody drug conjugates. And what exactly are these antibody drug conjugates? Dr. Siddharth also talked about them earlier. So if you can see very clearly, it consists of an antibody. It consists of the linker, the payload, which is in most cases the chemotherapeutic agent, and then of course certain factors, which is the drug-antibody ratio and the conjugation site. These are important things to look at, because it is these things which are now able to, which are now going to give us what we want, which is the efficacy, and to a large extent, they're also going to be the determinants of toxicity. Now, what does the antibody determine? We know that the antibody determines whichever antibody we have linked it with that will determine where it is going to go. It is understandable. Whichever antigen is being expressed wherever, you will link it with the appropriate antibody. And that, to a large extent, contributes to target-mediated drug disposition, which is a clinically meaningful endpoint, which is increasingly being used in various trials, known as TMDD. Then is the linker. And again, linker-based classifications are many. There are many materials that are being used as linkers. And it is the linker stability versus the linker dynamics that gives us the payload efficiency, if you call it.
Dr. Shruti,
Right?
you
Yes.
have 2 minutes left.
Oh, okay. Right. So payload, and the last, if you see, is about, right, so we'll just move forward with this. And like I said, there are various types of classifications about antibody-based drug conjugates. You have the, the cleavage-based definitions, the classifications. Some are, I'd just like to take, half a minute here, that especially with ADCs, the first classification is important because some, if you see, are cleavable and the others are non-cleavable. That does not mean that the linker is not cleaved. The second one simply means that the non-cleavable linkers are cleaved inside the target cell only if the antibody is degraded, not before that. But with the cleavable ones, the moment the antibody attaches to the antigen, there is a possibility that the payload may be released, and thereby we may get certain effects which manifest as toxicity, which are also known as bystander effects. So I think I'll skip this because this was just something which, by which I was trying to explain the difference between the two. So these are some types of toxicities, as I was saying, because of the linker stability, because of the payload class. Which class of payload are we using? Whichever class we are using, it is obvious that the toxicities that you will get will be directly related to the class of the payload or the chemotherapeutic agent that we are using, and it can be any. With antibody drug conjugates, there has been a lot of concern about GI toxicity, pneumonitis, interstitial lung disease risk, and there is one important concept that we need to remember here, one which is known as the bystander effects.
Can you please wind up, ma'am?
Yes, sir. So I think I have kind of explained. So this is just a table that I'd like to show you here. This was about the recently, some of them are in approval stage and some are already approved. If you see, this is just a recent summary of the types of antibody drug conjugates that we have now started currently using. Even with ADCs, we have now started moving towards site-specific conjugation is one of the things that we have been using. Some novel linkers and novel payloads have now started being tried. And also multifunctional ADCs with dual payloads. Dual payloads, that is where we are now currently moving. So there were a couple of vignettes that I wanted to discuss, but we will skip all that and directly go to the take-home message. So what I'd like to leave you with is that there are three very central take-home messages here. Primarily, the first is that the delivery platform of all these advanced drug delivery systems are no longer just delivery platform. They are platforms or formulations or the entities that are now giving us pharmacokinetic properties. So that are now able to give us the right exposure, and particularly with ADCs, they only succeed if the linker becomes important. So I think with that, I can end. Thank you so much.
Thank you very much, ma'am.
Thank you for the opportunity that is given to me.
Having taken us through the wonderful, fascinating field of nanoparticle in drug delivery system, and also you have beautifully highlighted what are the characteristics of these nanoparticles, what are the pitfalls, and how best it can be overtaken. And also you have touched upon the recent advances which has been happening in this field. If audience has one or two questions, we can take up. If there are no questions, I think
Thank you, sir.
Madam can be reached even in the tea break session also. Thank you once again, Madam.
Thank you so much. Thank you
The
so
wonderful
much, sir.
talk.
Thank you for the opportunity. Thank you, sir.
Thank you.
Hello. Dr. Satyana, I have a question. Excuse me. See, whatever said and done, all these nanoparticle or new, these drug delivery systems, when at least some of them will be available in India at an affordable cost. Time scale, can you give a rough estimate?
Sir, as per my last information, a lot of them are being used currently, as per the latest update by the WHO as well as DGHS currently, almost 5 to 10% of these advanced drug delivery system based, even nano carrier based system and ADCs are currently available in India. The first question was about availability. Secondly, the cost I am not able to comment at this moment, sir, because I'm not really aware of the costs associated, but I'm assuming that they are coming at a very high cost. And sooner than later, we would expect them, hope that the cost becomes reasonable.
Next decade?
No, not next weekend, sir. Hopefully in the next decade, probably.
Yeah, let it not be a hope alone.
Okay.
Thank you, sir.
Thank you, ma'am.
Thank you once again for the insightful presentation. We truly appreciate the contribution of the speaker and the guidance of a chairperson. Thank you so much, sir. May I now request chairpersons to felicitate the most promising young MD pharmacologist speaker, Dr. Shruti Singh. And I'd also like to request the chairpersons to come forward and felicitate ma'am. This is a token of appreciation and gratitude. Please put your hands together. Thank you, sir. I would now like to request the organizing committee, Dr. Shivmurthy, HOD, Department of Pharmacology, and the organizing chairpersons, as a token of appreciation and gratitude, come forward and felicitate ma'am once again. Sorry, I would like to recorrect myself. I now request the organizing committee, Dr. Shivmurthy, HOD, Department of Pharmacology, to felicitate the chairpersons as a token of appreciation and gratitude once again. Thank you. Ma'am, you can step forward for the picture. Thank you, ma'am. Thank you, dignitaries. Thank you, everyone. We now proceed towards the next presentation. And to chair this segment, I would like to invite our respected chairpersons, Dr. Vimala Ananthi A., Professor, Mahatma Gandhi Medical College and Research Institute, Puducherry, and Dr. Prabhakar Patil, Professor, Navodaya Medical College, Raichur, to kindly come forward. Thank you. I now request the organizing committee to kindly introduce the chairpersons.
Dr. Vimala Ananthi, Professor, Department of Pharmacology, Mahatma Gandhi Medical College and Research Institute, Pondicherry. She is a strong academic contributor with 25 indexed publications, 10 book chapters, 80 citations, H-index of 4 to 5 copyrights in medical education, and award-winning researcher holding key leadership roles as Institute Research Committee member, secretary, and course coordinator, reviewer, guest speaker, and a resource person.
Dr. Prabhakar Patil, the Professor, Department of Pharmacology, Navodaya Medical College, Raichur, author of the prescription writing book for interns, Parascripto Interni, developed cost-effective methods for animal experiments and published 20 original articles. Thank you.
Thank you. Now I would like to request the chairperson, Dr. Vimala Ananthi A, to kindly come forward and take over the proceedings, and also request her to introduce Dr. Jita S, Professor of Pharmacology, GMC Thiruvananthapuram, who is also the most exceptional and promising young pharmacologist who will be speaking on the next generation antibodies and bispecific antibodies and conduct this session. Over to you, ma'am.
Good morning, everyone, respected dignitaries, esteemed faculty, dear colleagues and participants. So it is my pleasure and privilege to welcome you all to the next session on next generation antibodies and bispecific antibodies. So now I introduced the speaker for the next session, Dr. Jita S, who is professor in the Department of Pharmacology, Government Medical College, Trivandrum, Kerala. So during her career in various government medical colleges, she has worked as a deputy coordinator of Area Monitoring Center, and she's a nodal officer of Antibiotics and Stewardship Program. And she's a faculty of Medical Education Unit, and also a member of NTEP Committee, NIRF Committee, and a nodal officer of Young Innovator Program. And she has delivered various health talks in institution and all India area, and also actively involved in research works on environmental toxicity of pharmaceuticals. She has many original articles published in indexed peer-reviewed journals. Now, over to you, ma'am.
Thank you, madam, for that kind introduction. So, respected senior pharmacologists, respected senior faculties, researchers, academicians, and dear friends. Very good morning to one and all. Actually, I would like to thank Shivamurthy sir and the entire MPS organizing team for giving me this opportunity to deliver a talk on next generation antibodies and bispecific antibodies before this August audience in this grand academic event. So I'll cover this topic in the next 20 minutes based on these headings. Like, we'll go briefly through the history, then an introduction through the next generation and bispecific antibodies, then the various format designs of the bispecific antibodies, then the classification, the important pharmacokinetics and dynamics of the drugs, then clinical applications, adverse events, management, and the next frontiers. So, when we talk about this next generation antibodies and bispecific antibodies, we cannot go without mentioning the name of these great eminent people who were the pillars behind this. So, Sir Paul Ehrlich in 1900s actually formulated a very basic concept called magic bullets. So he envisioned that the drugs should target the specific cell or the specific pathogen without interfering with the healthy tissues. So this concept of magic bullets was envisioned by Sir Paul Ehrlich in the 1900s. And when he provided that dream, later the scientists George Kohler and Cesar Milstein in 1975 actually introduced the concept of hybridoma technology, whereby we were able to develop millions and multiple copies of monoclonal antibodies. So there began this development of monoclonal antibodies in 1975, and later they won the Nobel Prize in 1984. And so we all know this is the basic structure of a monoclonal antibody, And the important site of due importance for us in this topic is the variable regions. This variable regions at the tip of the antibody. The variable regions in the light chain and the variable region in the heavy chain, which is the antigen binding site. So for all the monoclonal antibodies, it is monospecific. The name suggests monoclonal antibodies, they are monospecific, whereas in bispecific antibodies, it is bispecific or multispecific. That means each arm will target a different antigen. So that is it's called bispecific. At least it should target 2 antigenic sites. That is why it is called bispecific. Whereas the traditional antibodies target 1 specific antigen, the bispecific antibodies target at least 2 antigenic sites on the tumor cell. So, and the first cell, the muronmonab, was the first FDA-approved drug which was developed in 1986, and that was against the treatment of acute organ transplant rejections. This was the first monoclonal antibody that was developed, muronmonab. Then came the trastuzumab and the rituximab. As we all know, trastuzumab targets the HER2 receptors and rituximab targets the CD20 receptors on the plasma cells, which is used in the treatment of multiple myeloma. And trastuzumab, as we all know, it is used for the treatment of breast cancer and gastric cancer, which is positive for HER2 receptors. Now the next generation antibodies, actually, under the next generation antibodies, there are basically important 4 strategic entities. One is the bispecific and multispecific antibodies, then the antibody drug conjugates, which our previous speaker, Dr. Shruti, has mentioned, then antibody fragments, that is single chain variable fragments and nanobodies, and FC engineered antibodies. So bispecific and multispecific means they target at least 2 antigenic epitopes or more than that. And antibody drug conjugates, as mentioned by the previous speaker, the antibodies are conjugated with specific chemotherapeutic agents targeting the cancer cell. And the third one is antibody fragments. As the name suggests, they are fragments, so they are single chain variable fragments of or nanoparticles of small size. And what is the advantage? They enables better tissue penetration, because being a small size, they enables better tissue penetration. And the FC engineered antibodies. FC engineered antibodies means the stem of the antibody, if the shape of the antibody is considered as a Y, the stem that forms the FC portion is engineered in such a way that the amino acids or the glucose moieties in the Y chain is altered so that the pharmacokinetic properties like half-life is improved, and immunogenicity, that is a very important serious problem caused by the antibodies, like you might have heard about cytokine release syndrome. So that immunogenicity problem that is caused by the antibodies can be modified by modifying the stem of the Y-shaped antibodies. Now, there are different format designs that is formulated. Mainly and broadly, it can be classified into 2 types: IgG-based bispecific antibodies and fragment-based bispecific antibodies. By IgG-specific or IgG-based bispecific antibodies, we mean the exact Y shape is retained in those antibodies, and various engineering techniques like triomab, knobs into hall, duo body, tetra body, and crossmap are various engineering designs that are formulated to engineer the IgG-based bispecific antibodies. And what is the importance or what is the clinical relevance of maintaining this structure? The increased T-half of the monoclonal of the bispecific antibody. That means when there is a Y shape, this Y-shaped end or the FC end will get bind to FcRn receptors, the neonatal receptor FC, and it causes a recycling and it prolongs the half-life of the drug. So that is the importance of IgG maintenance of that specific structure, the full structure of the antibody. Whereas in fragment-based bispecific antibodies, what is the importance? That is, when being fragments, they enables increased tissue penetration as well as improving the pharmacokinetics of the drug. And BITE, as we see in the fragment-based bispecific antibody, one name is written BITE, that is bispecific T-cell engager, which is a very, very important one engineering technique that is recently used in many of the drugs like blinatumomab, which is currently used for the treatment of lymphomas. And other fragment-based techniques that can be used are TCR mimic, then tandem diabody, and the DART. These are all various techniques, and we will see a pictorial representation of all these. See, IgG-based bispecific antibodies, we have triomab, knobs into hole, duo body, tetra body, and cross map, which are all engineering techniques. And when we look into the knobs into hole technique, which is a more commonly used one, we see that one bulk amino acid is incorporated. One bulk amino acid is incorporated into this this heavy chain portion, and a subsequent pocket is created on the other hand, so that only they can pair. We all know that when there is an IgG-based antibody production, there is always a problem of chain issues. What is this chain issue? Actually, chain issues means when we are producing these antibodies through human embryonic kidney cells or the hamster ovary cells, this single cell has to produce bispecific antibody. So this information is difficult for the cell to process in such a way that, because a single cell has to produce 2 antigenic epitopes binding sites. So that is a problem for this production. So when an antibody is produced in such a way, only 12% will be having that specificity, whereas 87% will leave pollutants. So purifying this 87% of the pollutants from this clonal population is a challenging process. So knobs into hole is a very commonly used technique that is used by introducing a bulk amino acid into the chain so that a pocket is created and they can only align in such a way that mispairing doesn't take place and chain issues can be solved in such a way. And fragment-based bispecific antibody, this BITE is the most commonly used bispecific T-cell engager, whereby one arm binds to the T-cell receptor and the other arm binds to the tumor-associated antigen in the cancer cell. So that is how it is bispecific. One arm binds to the T-cell receptor and the second arm binds to the tumor-associated antigen on the cancer cell. So that is why it is bispecific. And what is the importance of this bispecificity? You know that T cells there are cytotoxic T cells, and these T cells are bringing to close proximity to the cancer cells so that the cytokine action as well as destruction of the cancer cells can take place easily without the involvement of the major histocompatibility complex process that has to be take place otherwise. So there forms an immune synapse with close proximity of the T cell and the cancer cell. That is why this bridging is very important mechanism which is provided by the bispecific antibodies. The T cells are being to close proximity to the cancer cells, and immune synapse is created so that the cytotoxic action of the T cells is taking place easily without the involvement of MHC complex activities. Now, these bispecific antibodies can target various sites, like bispecific antibody bridging cells. 2 cells can be bridged like this T cell and the NK cell. So bispecific antibodies can act in such a way. Or the second possibility is bispecific antibody bridging the receptors. It can bridge 2 receptors, HER2 receptor or EGFR receptor. So bispecific in such a way. Or the third possibility is bispecific antibody bridging cytokines. The interleukin 12 and angiotensin 2, these cytokines are bridged. We see that in certain drugs that we use currently, for example, in hemophilia treatment or in the treatment of solid tumors like non-small cell carcinoma, or even faricimab, which is a bispecific antibody which is used in the treatment of neovascular, this age-related macular degeneration. This faricimab drug uses actually this technique, joining 2 cytokines together. That is actually currently used in India, faricimab, which is used in wet age-related macular degeneration. This procedure is being carried out. And the next possibility is binding a cytokine to its receptor. So all these are different bridging techniques that can be used by the bispecific antibody. Now, this is a very important classification. This is clinically useful because this is based on the mechanism of action. First one is the T cell redirection, where the CD3 on the T cell and the tumor-associated antigen is brought to an immune synapse. This is based on mechanism, and this is very important for drugs like blinatumab for acute lymphoblastic leukemia, teclistamab for myeloma, and tarlatamab for small cell lung cancer. Then factor mimetics. This is an important mechanism of action whereby the drug emicizumab will act as a factor 8, linking factor 9 and 10, which is important for the coagulation cascade. So this is how the emicizumab acts. It is helpful in the treatment of hemophilia, which is widely used in our country. Then the third one is the dual pathway blockade, simultaneous inhibition of pathways, which is used by amivantamab, which is used for targeting EGFR and MET, two receptors at the same time. This is used in the treatment of non-small cell lung carcinomas in our country. So amivantamab, emicizumab, all are used in our country. Then immune checkpoint dual targeting blocks two distinct breaks on T cells simultaneously. The programmed cell death protein and cytotoxic T lymphocyte associated antigen. So these are the different mechanisms by which bispecific antibodies act. Now, what is affinity? Affinity means the binding capability of a bispecific antibody to its receptor. We generally think that when the affinity is more, the activity will be more, but it is not like that. When the affinity is kept to a low minimum standard, the activity will be more, because we know that normally there will be expression of these receptors like HER2 receptors on normal cells. So what happens when there is a high affinity, the drugs will get bound to the normal cells. So when there is low affinity, the high content of the HER2 receptors on the tumor cells will have a more predilection, and low affinity drugs will have more binding to the tumor cells, sparing the healthy cells. So that is why affinity is kept to a minimum standard rather than making it much more unlike we expect normally. And affinity and avidity is two different entities. Affinity is targeting one receptor, whereas avidity is a combined affinity of all the receptors. We know that bispecific antibodies always target at least two receptors. So avidity is a combined affinity of all these cells. That is related to the pharmacokinetics of the drug. And many studies have proven, even in prostate carcinomas, that low affinity drugs have a better efficacy compared to high efficacy drugs. Now the valency which we have learned in chemistry in our original classes. Valency is a number of binding sites in the antibody, and it improves the efficacy, because when there are more binding sites, if one binding is not effective, the other arm which binds to the receptor on the tumor cell will provide a definite binding to the tumor cells. So even if one receptor fails, the other receptor binding will provide activities. So that is related to valency. All these properties are taken care of while developing the bispecific antibodies. One classical example is glofitamab, which has 2:1 valency, which means CD20 of two cells, B cells, two receptors CD20 are taken into consideration, whereas CD3, one receptor is taken into consideration. So 2:1 valency. Now the pharmacodynamics, the important thing that we should know is a ternary complex formation is taking place here. Ternary complex means three things. One arm, the effector cell, then the bispecific antibody, and the tumor-associated antigen. So this ternary complex formation is very critical and key for the activity of the bispecific antibody, because unless this ternary complex formation takes place, the activity of the drug doesn't take place. Once the ternary complex formation takes place, what happens is the T cells will release granzymes and perforins, which causes killing of the cancer cells. Perforins will perforate into the cancer cell, and granzymes will cause lysis of the cancer cell. So this ternary complex formation is very critical for the bispecific antibody to act. And we have seen the graph of log dose response curve in classical drugs. What happens to the log dose response curve of classical drugs? There will be a plateau after a certain concentration. But here in bispecific antibodies, the graph slowly drops down after a critical concentration. Why? Because this bridging doesn't take place. When there is a high concentration of the drug will bind to each receptor. This bispecificity doesn't take place. Each arm will get bind to one receptor like that. So the bridging doesn't take place if the concentration is high. What is the clinical relevance? If the tumor burden in a patient is very high, we should not overload the patient with drugs, because this supratherapeutic effect, which is called the hook effect, where there is suboptimal response happens. So optimal concentration is very important and a key for proper and effective treatment in cancer cells with bispecific antibodies, because overloading the patient will lead to low therapeutic efficacy of the drug. And a pharmacokinetic comparison, we know that, as already mentioned, the Y-shaped arm will provide increased recycling and increase the longevity of the drug, whereas the fragments will cause more tissue penetration of the drug. So pharmacokinetically, they are both different in their action. So these are some examples of pharmacokinetic activities and clinical applications. So in hematological malignancies, these are the drugs that are widely used in worldwide: blinatumab, teclistamab, mosunetuzumab, like that. In our country, teclistamab is used, and it is under phase 4 trial in many centers. And one dose of the drug costs about 4 lakhs, and that is the problem with taking this treatment. Now, solid tumors. In solid tumors, the bispecific antibodies used widely is amivantamab in our country. Others are tebentafusp and tarlatamab. Amivantamab is used in non-small cell lung cancer, which targets two receptors, EGFR and MET receptors. This is widely used in our country. The non-oncology indications, as we already mentioned, emicizumab for hemophilia A, binding the coagulation factors 9 and 10, and faricimab for neovascular age-related macular degeneration, targeting two receptors, vascular endothelial growth factor and angiotensin 2. These two drugs are used in our country. And advanced clinical applications, which include zanidatamab, catumaxomab, and cibisitamab for various cancers like biliary tract cancer, malignant ascites, and colorectal cancer. So these are the drugs used in world markets. Now, coming to dosing, as we already mentioned, loading the patient with bispecific antibodies will have a negative effect. So this dosing is very important. In day 1, the teclistamab, which is widely used in treatment of hematological malignancies, it is given as 0.06 mg per kg, day 4 0.3 mg per kg, and day 7 1.5. This is called step-up dosing, and this step-up dosing is very important to prevent the cytokine release syndrome. How? We exhaust the T cells of its granule liberation so that once the high dose or the full dose of 1.5 mg kg is given, the granules will be of less quantity in the T cells so that cytokine release syndrome doesn't take place. That's how step-up dosing is very important in the management to prevent the immunological response. And the second one, which is widely used, amivantamab, again, week 1, we split the dose again to prevent this immune response by splitting it into day 1 and day 2. The full dose is split into 2 doses in day 1 and day 2, and weeks 2 to 4, again, weekly infusions are given, and after week 7, maintenance every 2 to 3 weeks is given. It is actually dose-based calculation. If the patient is less than 80 kg, it is given as 1050 milligram. So in the first day 1 and day 2, we split the 1050 milligram into 2 if the patient is less than 80 kg, and if the patient is more than 80 kg, it will be 1500 milligram. Now, one clinical scenario. See how we can manage. Meticulous monitoring of the patient is very important to address the problem with immune response. A 66-year-old male patient diagnosed with refractory multiple myeloma admitted for teclistamab's step-up dosing. Step-up dosing, as we mentioned, stepping the dose gradually. And 14 hours after second step-up dose, he developed fever of 30 degrees Celsius, sinus tachycardia, and hypotension, which are the features of immune response. And oxygen saturation became 91% on room air. And hypotension was managed by IV fluids, and oxygen saturation was maintained by 2 liters of nasal cannula. And workup showed this ICE score, which is a score based on the encephalopathy scoring system, and is dropped to 6 from 10. And CRP and ferritin levels were increased drastically, which shows the immune response leading to cytokine release, and neutrophils was also increased. So again, the grading, which is an AST-CT criteria, that is an American standard criteria used for assessing the response of the patient, that is grade 2, and CRS grade 2 ICANS. ICANS is an important immune response which is related to the neurotoxicity of the drug. And one important differential diagnosis that should come to our mind is sepsis, because the patient is having fever, then low BP, then the CRP elevated. So sepsis should always be a differential diagnosis in this patient, and empiric antibiotic therapy like third generation cephalosporins or meropenams can be started. And the targeted approach for treatment is interleukin-6 antagonist, tocilizumab, and steroids like dexamethasone. So these 2 drugs are very important for the managing immune response that can be very deleterious to the patient, that can happen commonly, and these 2 drugs are life-saving, tocilizumab and dexamethasone. Within 12 hours, patient the fever was subsided and weaned off oxygen. ICE score got up to 10 from the 6, and later treatment protocol was completed with a bispecific antibody. So what we understand is vigilant monitoring, pharmacovigilance monitoring is very crucial while treating with bispecific antibodies. And one more case scenario, the second one is a 66-year-old female, weight 60 kg. Why 60 kg? Because for some treatment options with the body weight is very, very important. 60 kg, diagnosed with stage 4 lung adenocarcinoma with EGFR exon 19 deletion and exon 20 insertions are 2 important entities where we use amivantamab. So that is the key. Exon 19 deletion and insertion of exon 20 is key for treating with amivantamab. In 18 months, partial response was obtained for this patient, but routine follow-up showed that there is multifocal disease spreading of the disease. And molecular findings showed that there was persistence of EGFR mutation and MET oncogene application. Then what is the next treatment option? So there comes the importance of amivantamab. So there, when the relapse or refractory cases happens, there we go for amivantamab as the treatment option. And see, the management can be completed with the drugs of 1050 milligram because the weight of the patient was 60 kg. If it was more than 80 kg, it would have been 1500 milligram. And with amivantamab, there was 42% reduction in the target lesions. And what are the important adverse drug reactions that we expect with bispecific antibodies? As already mentioned, the most serious one is the cytokine release, characterized by fever, hypotension, usually during the first or the second dose of the drug. So to prevent or mitigate that, step-up dosing is very, very important. The another one is ICANS. This is a neurotoxicity that is expected with this bispecific antibody, characterized by confusion, altered consciousness, tremors, and Broca's aphasia or motor deficit in speech. Now, the third important adverse drug reaction that we expect on target of tumor toxicity is due to the presence of these receptors on other cells other than cancer cells, so they can cause skin rashes and diarrhea. Then hematological and infectious risk is another important adverse drug reaction that is expected with the bispecific antibody. Increased risk of opportunistic infections, and hematological risks include low count of the blood parameters. Now, what are the important drug interactions that can happen with bispecific antibodies? Even the cytokine release itself, this immune modulators that is released in our body can cause this inhibition of cytochrome P450, whereby most of the drugs that is metabolized by cytochrome P450 can be affected. So that interaction should be kept in mind while addressing with the bispecific antibody administration. Then immunosuppressant antagonism. This corticosteroids that is used for as a pre-medication to treat this disease condition can blunt the effect of the disease condition. And this thromboembolism risk is another important drug interaction that can happen with bispecific antibody. Then vaccine-associated infection is another important drug interaction that can happen. And infusion-related reactions. These are the important drug interactions that can happen with bispecific antibody. So the next frontiers of bispecific antibody are the trispecific and tetraspecific antibodies, which will bind to multiple receptors so that the immune synapse formation is more meticulous and that the destruction of the cancer cells can take place more effectively without the involvement of MHC complex formation. And actually, there are many clinical trials that are going on with the bispecific antibodies, like MACTEC trials and Mariposa trials. Actually, they are all clinical trials that are going on to look over the importance of the bispecific antibodies, the overall survival rate, as well as the longevity of the patient, as well as the efficacy of the drug. So actually, these bispecific antibodies was initially started originating in 2015 onwards only, and many of them have been marketed in 2022. So data regarding that clinical trial is still on the pending side. So again, more clinical evidence has to be gathered because bispecific antibodies is slowly being used in our clinical settings. So that's about the bispecific antibody topic. I think I could cover with the time. Thank you.
Thank you, Dr. Jitta. That was an excellent presentation as well as fast presentation. Now we'll open the session with one or two questions for discussion.
Actually, sir, for teclistamab, per dose it costs 4 lakhs.
That is, I think, an important limitation that is currently means in the therapeutics. So that is a very big question, whether it is in the reach of the common people there. So that is the main problem. Thank you.
Excuse me, ma'am. The question is, from R&D to manufacturing scale, the batch failure rate for these drugs is very high. That's why the clinical trial which was ongoing was stopped because of batch failure. Okay. And in India, we don't have one manufacturing of this type of drugs. Major manufacturing happens in Japan. Okay. So these are also coming under tag of FDC biologics. A new concept of FDC biologics is coming up. So under this they are coming. And the most challenge is to make 1 gram of a drug, I take 1 year. And by the time the expiry date is only 6 months. So we have to develop new technology for manufacturing. This is what we see. That's a challenge for us. Thank you.
If at all some drugs has to be given to the patient, they have to be imported from outside. That's also very costly. Actually, CDSO regulations are there, and they have to get consent from CDSO for importing the drugs from outside the country.
Okay, if there are no more questions. Ma'am, I have a question from your ma'am, from chairperson side.
Okay.
So as a pharmacologist, what do you think, apart from cost, a major barrier for translating these molecules into therapeutic practice?
Actually, being bispecific, this development is very crucial because, as I already mentioned, normally these antibodies are developed using human embryonic kidney cells or the hamster ovary cells. So these cells are given the data of producing this bispecific antibody from a single cell. So a single cell has to produce these bispecificity. So that is a key critical problem there. And as I already mentioned, only 12% of this whole population will be bispecific in the correct sequence. This Y-shaped antibody, they will have a problem of chain mispairing. This heavy chain can get mispaired with a light chain in various combinations, permutation combination way. So that heavy chain issues is another problem that is going to be faced by the pharmaceutical companies.
Okay. Thank you, ma'am. Thank you again for that excellent presentation, ma'am.
Thank you very much.
Thank you once again for the excellent presentation. We appreciate the valuable insights that's truly shared among us today. Now, I would like to request the chairpersons to felicitate the most promising Young MD Pharmacologist Award to Dr. Jitayas. Ma'am, please come forward. Thank you. Thank you, everyone. Thank you, everyone. We would now proceed towards the next presentation. Now, I request the chairperson, Dr. Prabhakar Patil, to kindly take over the proceedings and introduce our next speaker, that is none other than Leila Teresa Contessa Cremona, founder and CEO of Medibay and IQ Training, UK, who will be speaking on evidence-based medicine in the era of AI and conduct this session. Over to you, sir.
Good morning, everyone. So, the topic is evidence-based medicine in the era of artificial intelligence. So, the guest speaker, Madam Leila Cremona, founder and CEO, Medibay. Now, I request Madam to start with her presentation.
Good morning. Very lovely to be here, and thank you, Dr. Shiva, for inviting me, and thank the board and the other officials here for tolerating me for being on the wrong day. So thank you, Doctor, for allowing me to take your place today. So I'm here to speak on evidence-based medicine in the era of AI, from data to decisions and to humanity. And that's very important. So I want you to think about this. In one part of the world, a patient can receive a diagnosis in minutes using AI. In another part, that same patient may be walking miles and miles just to see a doctor. And the question is not whether AI will actually change medicine, but who's it actually going to change it for? So after a morning of brilliant science, I hope you'll bear with me, because I'm not one of your wonderful professors here. I'm more involved in humanity and creating access using AI to give everyone the opportunity to have proper, fast access to healthcare. So let me ask you something. I'm going to do this all the way through because I need to keep your attention and make sure I'm not too boring. How many of you actually believe we already have the knowledge to treat most common diseases? Can you show me a hand? Do we have that knowledge? Yeah? Oh, I've got one person over there. Yeah, another one over there. Shall I ask the question again? Right. Who thinks we've already got the knowledge to treat most common diseases? Yeah? Okay. So the problem isn't knowledge. The problem is access to that knowledge. And let's do something simple. If you believe access to healthcare is still one of the biggest challenges, raise your hand. Yeah? Are you out there, everybody? Are you listening? If you believe that access to healthcare is still one of the biggest challenges, can I see your hand? Yeah, thank you. And that is the reality we're actually working in. This conference speaks about smart drugs, smart data, smart decisions, but I'd actually add in smart humanity, because without that, I'm sorry, am I ruining your day? Oh, I can't do it both. Oh, okay, there we go. Ah, we've done that one. So, smart humanity, because without that, the rest doesn't matter, does it? Scientific rigor. Because evidence-based medicine... Oh, thank you. All right. You'll have to excuse me. I actually had food poisoning before I came to India, so I'm not at my best at the moment. As I said, smart humanity. Because without that, as I said, the rest doesn't matter. Because evidence-based medicine has given us scientific rigor, clinical safety, and standardization. So, let me ask you something. When was the last time evidence reached everyone who needed it? Because evidence-based medicine is slow, selective, and unequal. Evidence without access is not evidence in practice, and evidence without context can become ineffective. AI is transforming medicine. We're moving on from evidence-based medicine to intelligence-driven medicine. And AI can analyze millions of data points. It can predict outcomes. It can personalize care. But let me ask you this. How many of you would be comfortable allowing AI to make a clinical decision without any human oversight? I know I wouldn't. And this is where the real challenge lies. It's trust, not technology, that's the issue. Because AI does not remove bias. It can amplify it. And AI will not fix health inequality unless we design it to. Because AI is like a child. It will only learn what you teach it. If you teach it the good stuff, it'll learn the good stuff. If you teach it the bad stuff, it can be deadly. And just to be clear, AI will not replace clinicians. It's not going to replace you. AI will not do that. But clinicians who use AI will replace those who don't. And let's be honest, in India, even if AI were perfect, most patients would still want a second opinion and a third opinion from the family. So, before I move on, I've got to admit something. One of the things I love about Bangalore is the food. It's amazing, isn't it? And I'm so sad because I really am quite ill and I can't enjoy it. And India, when someone asks if you're hungry, they don't really mean it, do they? And I started thinking, wouldn't it be amazing if healthcare worked like that too? If people didn't have to ask, if it was just kind of there. So, let me take you to a moment. You have a mother in a rural village. Her child has a fever. She doesn't know if it's serious. She doesn't have that knowledge. She can't easily access care. So what does she do? She waits and she prays. Let me ask you, if that were your child, if this was you, would you be comfortable waiting, or would you be stressed and upset beyond belief? Uncontrollably distressed? That moment is not just a medical problem, it's a system failure. Now imagine the same problem, another patient, say middle class in a city, same symptoms, within hours they'll have a diagnosis, a consultation, and they'll get pretty accurate treatment, won't they? Completely different outcome. Healthcare isn't failing because of lack of knowledge. It's failing because of lack of access. Before I continue, can we do something a bit different, just for 10 seconds? I'd like you to maybe ask the person next to you, or think about it if you haven't got anybody next to you, what is the biggest barrier to healthcare access in your experience, your personal experience? Can you give just one word to that person to express what you believe is that barrier? Perhaps I could ask anyone, is there anyone here that can shout out what they think is the one barrier? You're all so beautifully shy. We don't get this in the UK. Okay. You'll have heard different answers. Cost, distance, trust, and infrastructure. And that is exactly the complexity we need to solve. Now you'll see Medibay on the board here. I'm the CEO of Medibay, and if you'll allow me to get a little personal, Medibay's my baby. I'm the founder, and we launched her at the Houses of Parliament in the UK in April of this year, and we've been working on her for 3+ years. My fellow directors, Karen Reiki and Professor Federico Baffetti, who was going to be here but is suffering himself, built Medibay on one belief, and that belief is that every individual is entitled to swift, effective healthcare, irrespective of their sex, their colour, religion, geography, or financial circumstances. And we didn't just say it, we built it. And we have Medibays built and ready to go for humanitarian purposes and for primary healthcare. And yes, I call Medibay she, because I see her like a mother, a system designed to care, protect, and guide. And like any other mother, she tries to give you the right answer, even when you don't follow the instructions. Now imagine this, a patient walks in, within minutes, she can make sure a doctor is present live, able to converse with them in a preferred language, complete full diagnostics, and that includes taking ultrasound, handheld x-ray, 30 times magnifying camera, blood, fecal and urine tests we can analyse in situ between 5 and 25 minutes. Okay, so no waiting. We give that information to our live physicians, and that's done through AI into a central hub where they are remote, and they can provide the proper diagnosis and assessment and proper care. That's what Medibay is all about. A fully informed clinical decision where the doctor sees the patient, their history, their results, and provides a clinically accurate, effective pathway. But healthcare has to be accessible, affordable, and intelligent, and most importantly, accurate and effective. Because access without accuracy is dangerous, and affordability without effectiveness is meaningless. Now imagine the same mother again, but this time she's got access. Our rural lady has access through a Medibay humanitarian pod. That's not innovation, that is dignity, that is equity, and that is justice in healthcare. So let's talk about something we don't always discuss openly. Money. Yeah, I've learned something during my time in Bangalore. People here don't like to talk about money, but they are very, very good at managing it. And I lived in Bangalore a long time ago for about 10 years, so I'm almost Indian. I'm not so good with the money part, though. During that time, I saw something that stayed with me. I met families who were not just dealing with illness, but dealing with the cost of illness. Families who'd taken a debt, sold their small amounts of gold or other assets, made sacrifices just to ensure that a loved one could receive proper treatment. And in some cases, it didn't just affect one person, it pushed entire families into poverty. I remember thinking at the time, illness shouldn't destroy a family's future, and yet this is still the reality for many. Because evidence-based medicine tells us what works, but it doesn't always answer what people can afford. And a treatment that can't be accessed doesn't exist. Healthcare is not just science, it is human. And compassion, your compassion, will never be replaced. So, quick show of hands. I want to check you're still awake and not too bored. How many of you believe technology alone can solve healthcare equality? Anybody? No. Exactly, it can't. Unless we design it to. And unless we design it with humanity. Ask yourself, who is being left out? Because if one group is excluded, the system is incomplete. So, I know it's not quite lunchtime yet, but in Bangalore, you never leave a meal hungry. I'm talking a lot about food. I haven't eaten for 3 days. But too many people still leave healthcare without answers. So I'm going to leave you with 2 questions to think about. If your system works perfectly, but millions still can't access it, is it truly working? And more importantly, who is still being left behind because of the systems we're working? Because the future of healthcare will not be defined by how intelligent it is and how much AI we use. But it will be defined by how many people it actually reaches. So, thank you very much for listening to me. And it's a pleasure to have been here. Thank you.
Thank you, ma'am.
Thank you.
So, if you are having any question, please.
Sorry. My apologies. Yes, sir. I'm old and deaf, so perhaps I don't know.
Can you hear me, madam?
I can, thank you, sir.
No, are we hyping this AI as far as medicine is concerned? That is number 1 question. Are we turning a blind eye to the other possibility that AI, the word artificial intelligence, everybody is familiar with, is it making us artificial idiots?
Sorry, you're asking me if AI is...
Or to put it in other way, are we becoming over-dependent, forgetting our inherent clinical, acquired clinical acumen?
No, I think what you have to be aware of is that we need to use... AI is essential in order to deliver accurate diagnosis, whether we're using machines or other forms of equipment within the system with platforms. So, for example, with Medibay, all of our diagnoses are instantly checked. We use AI within Medibay to translate immediate translations for patients and doctors. So we have communication, we have accuracy in the tests. But what I'm saying is that AI won't work, no matter how brilliant and perfect it is in the system, if we don't keep the human part in it. And AI must work in a good relationship with humanity. I don't believe for 1 minute that, for example, in China, you can have a fully AI hospital. I think that's awful, because I know that doctors, physicians, there is something with them that they are taught that you're teaching here that can never be replaced with AI. There is a way of looking at a person. There are things that are identified with the person that uses something within the humanity, within each of us, that can help patients and identify things AI simply is not and will never be able to do. The human element. Does that answer your question?
Thank you.
Thank you very much. Yes, guys, one of you up there. Again, remember, I'm old and deaf. Oh, I'm running over. So I'll be here if you want to ask me, because we're running over. Okay, I'll be down here.
Thank you once again for such an insightful and engaging presentation. I think everyone enjoyed it truly. Thank you once again. Now I'd like to request the chairpersons to felicitate the distinguished invited guest speaker, Leila Teresa. Ma'am, please come forward. Can we give her a huge round of applause, please? Thank you so much. Thank you, everyone. Now I'd like to request Dr. Shivmurthy, HOD Department of Pharmacology, the organizing chairperson, to come forward and felicitate our chairpersons.
We request our Director A.C. Ashok sir and the Vice Chancellor Satnarayan sir to kindly take over the seat in the front stage. Sir, please. A big round of applause for Director Sir and Satnarayan Sir. Ili.
Once again, a warm welcome, sir. Welcome, sir. Thank you so much. Sorry for the small delay. We now proceed towards the next presentation. To chair this segment, may I invite our respected chairpersons, Dr. S. Narayan Reddy, Professor and Head, Mount Zion Medical College, Kerala, and Dr. Sansita Parida, Professor, Institute of Medical Sciences and Some Hospital, Bhubaneswar, Odisha, to kindly come forward onto the stage. Now I'd like to request the organizing committee to kindly introduce our chairpersons.
Good morning, everyone. I now introduce you chairperson for the next session, Dr. Sansita Parida. She is a professor in the Department of Pharmacology, IMS and SUM Hospital, Bhubaneswar. She is a dedicated academician and an excellent researcher with expertise in the area of medication error prevention and patient safety. She is also a member of Pharmacovigilance Committee, and she is a part of Institutional Ethics Committee, working as a basic medical scientist. I welcome you, ma'am, and I request you to chair the session.
Good morning, everyone. It's indeed a pleasure to invite Dr. S. Narayan Reddy, sir, Professor and Head, Department of Pharmacology, Mount Zion Medical College, Kerala. He is a former professor and head at Sri Atal Bihari Vajpayee Medical College and Research Institute, Bengaluru, recipient of the Eminent Teacher Award and Mentor of the Year Award 2025, former Member Secretary, Paramedical Board, Government of Karnataka. We welcome you, sir.
Thank you so much. I would now like to request the chairpersons, Dr. S. Narayana Reddy, sir, to kindly take over the proceedings and to introduce Dr. Pavan Malhotra, Director, Principal and Professor of Pharmacology, Acharya Shri Shandor College of Medical Sciences and Hospital, Jammu, who will be speaking on translational challenges from bench to bedside and conduct this session. Over to you, sir.
It's a pleasure to introduce Dr. Pavan Malhotra, presently the Director, Principal, and Professor of Pharmacology at MPSCON's and MPSCON's Hospital, Jammu. I think it's Acharya Chandar. A refers to
Acharya Shri Chandra College of Medical Sciences and Hospital, Jammu.
Better, thank you very much for that. I thought you would come online. Glad to have you here on the stage. Let me not waste your time. As the time goes on, you'll become familiar with and his work. Thank you. You can go ahead, sir.
Thank you very much. At the very outset, I would like to thank Dr. Shivamurthy for inviting me to this MPSCON2026. You know, I have been away from pharmacology for the last 10 years. I am into administration. So Dr. Shivamurthy has made an effort to bring me back to the fold of pharmacology. So I am really thankful to Dr. Shivamurthy to remind me of the roots of medicine. My today's talk centers on one of the most critical missions in modern science, turning data into diagnostics and molecules into medicine. Moving a discovery from bench to bedside is a monumental challenge. It requires fusion of science, business, regulation, and clinical expertise. Now, over the next few minutes, we'll have a look at how and why this transition has become difficult. And I'll try to explain some ways and means how we can work together to bring life-saving innovations to the patients at a much faster rate. So with these opening remarks, I seek permission from the chair to start my presentation, sir. Thank you. I bring greetings from the holy shrine of Shri Mata Vaishno Devi Ji and a serene and beautiful city of temples, that is Jammu. So I have divided my presentation into two parts. One is the translational challenges from bench to bedside. What are these translation challenges? Number two is how to bridge the gap between these challenges. Well, I was not asked to make a second part presentation. Still, I thought that would be appropriate if I give my ideas and some scientific ideas how we can bridge the gap. So, the part one is challenges from bench to bedside. We need to understand, this is for young undergraduate students, postgraduate students, we need to understand these terms, what is bench and what is bedside. Medical discovery from the bench means the scientific experimentations being conducted in the laboratory. So lab becomes the bench. And carried out to bedside. And the bedside, when we say bedside, it is the hospital and the patient, the clinicians and the patients. The path is notoriously difficult and generally referred to as valley of death. I'll explain what is this valley of death. Statistically speaking, only 10% of the investigational drugs that enter the human testing phase eventually receive the approval of the regulatory authorities. Only 10%. The average timeline from discovery to the market ranges from 10 to 15 years. So this is the valley of death. You can see on one side there are number of people standing are much more than the other side. Where the number of people standing more is the bench side. There are many experimentations going on. Some lead to the success and most lead to the failures. And on the other side, you see this side. This is the bedside where the clinicians are ready to receive the molecule which was conceptualized here, tested, conceptualized, got approval, and then this is this when it was tested, it has to come down this into the gorge and then climb up. This is the period which takes about 10 to 15 years. So what are the challenges or the barriers? These are broadly classified as scientific challenges, regulatory challenges, and the cultural challenges. So I'll take up one by one. The scientific challenges. The scientific and the financial challenges, which includes the valley of death. The most critical bottleneck occurs where basic research and phase 1 clinical trials are being conducted. Number one is the predictive efficacy. Many treatments work perfectly in the mice or cell cultures but fail in humans. Number of experimentations were more. number of discoveries were less. The animal models often do not mimic the complexity of human biology, thereby leading to a false start. Second point is reproducibility crisis. The significant portion of the academic breakthroughs cannot be replicated in the industrial settings. Now, if the industrial settings are not getting their desired response, they will hesitate in investing millions and millions of dollars or rupees, as the case may be, on unproven data. They will never ever invest on unproven data. Then there are funding gaps. Government agencies like ICMR, DST, DBT, they fund basic research. The private investors, as the pharmaceutical companies, they invest in later stage trials. But the middle ground often remains underfunded. And this is the basic challenge why there has been so much time taken by the drug to come into the medical market. Now the regulatory challenges. If the drug works navigating the path or to the patient, it involves high-stage logistics. The first is patient recruitment. Finding enough eligible patients, especially for rare diseases, it can take years and years, generally leading to stalling of the research program. Maybe you find one patient in 2 years, or you find 2 patients in 1 year. Again, the number is not satisfying. Then the regulatory complexity. Navigating the regulatory authorities, it requires immense documentation for what is called as the good manufacturing practice guidelines. And unfortunately, the academic labs are rarely equipped to handle with such kind of guidelines. Then standardization data. Data from the hospital or the labs often use different formats, making it difficult for a statistical analysis and coming out with a clear picture. Then cultural and structural challenges. The bench and the bedside often speak different languages. When I say different languages, that means the interpretation is in their own form. The incentive mismanagement. The academic scientists are awarded or rewarded for publishing high impact papers. For scientists, the reward is to publish a good paper in a very good journal. While as the clinicians and the industry wants safety and efficacy of the product. So there is a misalignment of the incentive. Then there is a siloed knowledge. Basic scientists may not, I'm not saying every time, but may not understand the practical realities of clinical care. While as clinicians may not understand the molecular nuances of the experimentation or the drug therapy. Now, if I summarize the challenges, scientific challenges, we have species differences, lack of biomarkers, and reproducibility. The financial, we have high cost phase 1 and phase 2 trials, and valley of death funding gap. Logistical challenges, we have patient enrollment, issues with patient enrollment, multi-center coordination, and data privacy. Then lastly, about the regulatory, we have stringent safety requirements, and there should be an evolving drug trial design standard. One thing we should understand, the primary challenge before all these challenges which we have discussed is that human biology is context dependent. What happens in a petri dish or a genetically identical strain of mice, it rarely mirrors the messy and diverse reality of human biology. A drug might effectively kill the cells in the tray, but can be neutralized by the human immune system or may prove toxic to human liver. About the funding gaps, the statutory funding bodies pay for basic research, but pharma industry will not support till they are ready to buy. And when they are ready to buy, whenever they see that there are some kind of promising results. So there arises a conflict of interest. Coming back to statistics, only 1 in 1,000 compounds, they reach human testing phase. Now the hurdles. Reproducibility crisis. We have mouse problem. Mice should not be considered as a miniature human. Success in animal models may or may not correlate with the human efficacy. As far as data integrity is concerned, up to 50% of the academic research results cannot be replicated in industrial setting. And lack of biomarkers, we have already spoken. We need to know whether the drug is actually hitting the targets in the early human phase, early human trials. Hurdles, the human element. Patient recruitment, I have already spoken. Heterogeneity. As I've already told you, lab mice is genetically identical. And every human being, we all are we belong to same species, we are sitting in one hall. We have different genetic composition, different dietary habits, different comorbidities present. So they will be the limiting factor in human trials. Even if the animal trials have shown wonderful results. But if same drug is exposed to all of us, the results would be totally different in each one of us. Results can be totally different in each one of us. So safety versus efficacy. We need to find therapeutic window to declare a drug safe. So that is very difficult to know whether the drug, what is the therapeutic index of the drug in early staging. Now the regulatory and manufacturing roadblocks. About GMP standards, I have already spoken. Rigid trials, one size fits all approach. This is a very common terminology which is used. We need to understand the physiology of child is different from that of adult, and physiology of silver age group people, that is the older age group, is again different from an adult. So ladies and gentlemen, it is high time that geriatrics should be declared as a separate subject. It should be declared as a separate subject. And because there is the physiology in the silver age group is declining. This is not the same as that of an adult. So the cultural divide, if you visually see, there is a wall between a person in apron and person in scrubs. Researcher wants publication, Clinician wants cure, and now the third stakeholder is industry. Industry wants return on investment. They will never ever fund any kind of a project which can lead to a failure. Now the language barrier. The basic scientists and the researchers, basic scientists or the clinicians, they use different terminology for same biological process. Basic scientists use the term ligand receptor affinity or target engagement site, while as clinicians would use it as clinical efficacy or therapeutic response. The basic scientists will use off-target effects or cytotoxicity. The clinicians will use adverse effects or side effects. They are using same terminology for different processes. Same process, different terminology. Now, how to bridge the gap? I'll just hurriedly go through it. Now, this is the picture of a railway bridge, highest railway bridge in the world, which is present in my state of Jammu and Kashmir, which is now operational, connecting Kashmir to rest of India through railway network. So on one side you can see this is the bench, and the other side is the bedside. Now this is the valley of death. Now we need to bring this bridge down and connect these two. So for that we need to understand what is linear chevron. Year 1 to 10, first 3 years, we have basic research, discovery and exploration, and clinical studies. 4 to 6 years, clinical trials, phase 1 to 3, along with regulatory approvals and access. 7 to 10 is clinical application and health impact. So this linear chevron is required to be understood. The failures and successes, I'll give you only one example. Alzheimer's disease is very well known disease these days. We claimed that there are a lot many drugs which have very positive results. And what were those results? They were all animal studies. There's been a total failure of, nobody has been able to cure Alzheimer's. No molecule has been able to be this labeled as a very effective medicine in management of Alzheimer's. On the other hand, the mRNA vaccine, it shows huge translational success. What was the reason? What went wrong was the poor target selection. We relied on the animal results, and we declared that these are the drugs which can be used. What went right was, in case of mRNA vaccines, was the cross-sector collaboration. So strategies for success, we have open innovation, adaptive trials, patient advocacy, and venture philanthropy. So we need, for open innovation, we need sharing data between the academia and the industry at an early stage. Adaptive trials, we need to use artificial intelligence and real-time data to change the trial parameters mid-study. The patient advocacy, with this we need to involve the patients in the design process to ensure that the bedside needs are met first. And venture philanthropy is non-profit funding organization funding the valley of death gap. So infrastructure and funding gaps are to be brought nearer. We need to establish joint centers for conducting basic research and clinical trials. Create translational specific grants. We need to allocate dedicated funding loops specifically for moving validated laboratory targets into phase 1 clinical trials. Funding the multidisciplinary team, we need grant applications to both fundamental PhD students as well as the practicing MD clinicians. We need to develop shared biobanks. We need to maintain centralized repositories of high quality human tissue samples which are linked to electronic health record. So I know my time is over, I'll just hurriedly go through this. Expand the PhD, MD programs. Dual degree program should be instituted, in which the aim is to create a professional which is fluent in both research as well as in clinical care. We need to immerse basic scientists into clinics. The idea is to give them involve them in grant rounds to observe the real world disease pathology. Value translation in academia. We need to update the universities towards the policy of publications. They should be rewarding for patents, clinical trial designs, and data sharing over publications. Then deploy the boundary spanners, hire dedicated translational project managers to facilitate the communication between the two groups. This is important. Methodology and technology. We need to prioritize the human-centric models. Use organoids, microfluid organs on chips, patient-derived xenografts. Instead of animal experimentation, such kind of things should be introduced. Standardize the laboratory protocols for smooth scaling. Utilize digital twins to employ predictive computer modeling and artificial intelligence to screen compound toxicity prior to human testing. Sir, you said, probably you raised the question of artificial intelligence and artificial idiots. I would say nobody can replace humans. We are only employing artificial intelligence to reduce the gap. The time gap is reduced. We are not saying that it is replacing the humans. I would say it is always the man behind the machine matters, not the machine matters. It is man behind the machine matters. So engage the regulators early, standardize the intellectual property, involve the patient advocacy group early in the design. Whenever you design a protocol, then only you involve the group. So to summarize, translation is not a straight line. It is a feedback loop, and we have to take care of every loop of this feedback. The future is on AI-driven drug discovery, organ on chips, and personalized medicine. Now I have tried to bring down that highest railway bridge to connect the two ends. Now you see these two ends are connected, and this is the train proceeding to Kashmir Valley. So the train is not important. It is important that a bridge has been created so that the knowledge moves from one end to another end and vice versa. So closing thought is, innovation is not a product. It is a process of persistence. This is my institution where I work. Thank you very much. I had 2 videos which are not working. Thank you very much for very patient hearing.
Hope Dr. Pawan Malhotra has succinctly put all aspects of the topic. I don't have to repeat them again. I presume there are going to be some questions, if there are any. Honor him with few questions. Oh, is always some factor. It's the time factor now.
I am here to answer any query which is there because of paucity of time. No, there's a paucity of time. The dignitaries are waiting for inauguration process. I am ready to answer your questions. We can I can answer later on. Thank you very much. This is the requirement of the management. I am not running away from the questions.
Okay, thank you very much, sir. So you're also anxious. You don't like to see the dignitary sitting there for a long time. Neither I would like to consume a lot of everybody's time, rather. You have succinctly, clearly summarized the issues, all issues associated with this particular topic. I'm surprised you have come back from administration back to this. And the same thing should happen here. When clinicians outwardly discard whatever happened on the bench, blindly throw it back like a tissue paper, what we have to do? We have to come back to the bench again. Look at it in a different way. Ask many more questions. Ask what we missed, what went wrong. I think that should be the attitude. Always, as everybody knows, I'm sorry to put it curtly, that the clinicians who take your molecule and try to test on some people are always trying for one-upmanship. That always persists. It has always happened. It is continued to persist. Yes. Now the thing is, this I cannot resist the temptation to quote a Chinese proverb which I came across. Basically, you compare those clinicians to dragons, very mighty and powerful. If you ignore the dragon, it will eat you. If you confront it, try to fight it out, it will overpower you. If you ride on the dragon, you might use it for your advantage, its might and power. Okay? The best way to overcome an obstacle is to pass through it. And the best way to do it is proper communication rather than manipulation, which everybody is trying to do, at least as we know. It's an open secret, but generally these are not spoken about much in a public platform. The sponsor is under pressure, basic scientist is under pressure, clinicians are under pressure, and all those involved trying to get their names in the public. Everybody is under pressure. It's today a pressure situation. Thank you for giving me this time. Let me give it to my co-chairperson to say. Otherwise, they will all start yelling at me. Everybody is talking about woman power. Please excuse me. I will hand over to the woman power now.
Sir, I wanted to talk on many aspects, but time is short. Just I would like to say that whatever from bench to bedside, to bridge the gap, the manufacturers, they are the main person who are promoting these trials, which we are seeing in our institute. So many trials are going on. The clinicians, they are they want to publish papers, and that is their benefit. So they are ignoring the people who are doing the trials actually are the manufacturers or some people who are appointed by them. That is what is practically happening in many places. So I would like to say that the ethics is the one thing that can actually do this. Ethics of the person who has done.
Never ever be overruled.
Yes, that is what is happening. Though we are, yes.
If you remember one of my slides, I told that industry wants return on
yes, exactly, sir.
That is,
so how to?
Return of investment is the target. That can become unethical.
So that should be a rule, sir. Like financials should not be there. This conflict of interest should not be there. So those trials should not be promoted actually. Okay, sir. Thank you for your time.
Thank you so much. Thank you for that outstanding and thought-provoking presentation. We truly appreciate the valuable insights that's shared. May I now request the chairpersons to felicitate the most promising senior MD pharmacologist speaker, Dr. Pawan Malhotra. Thank you everyone. Now I'd like to request Dr. Shiv Murthy sir, HOD Department of Pharmacology, to felicitate the chairpersons as a token of appreciation and gratitude. Once again, I'd like to thank you all. Thank you to all our distinguished speakers and respected chairpersons for an excellent and insightful scientific session. Thank you, everyone. Ladies and gentlemen, now we shall proceed towards the inaugural ceremony. I hope everyone's ready. Before we proceed, knowledge grows when shared, and excellence emerges when minds unite. With that, it gives me immense pleasure and honor to extend a very warm welcome to all the eminent dignitaries, respected guests for the inaugural ceremony of MPSCON2026 International Conference hosted at CDSIMER Dayanand Sagar University, Bangalore. We are truly privileged to have among us several distinguished personalities whose presence adds grace and prestige to this very occasion. We also would like to take this opportunity to acknowledge, to grace the dais with his esteemed presence. We'd also like to take the opportunity of honoring our Chancellor, Dr. Hemchandra Sagar, Sir Dayanand Sagar University, a visionary leader and guiding force in academic excellence. Sir is not present here with us, but his unwavering support is always amidst us. I would also like to honor Dr. Premchandra Sagar Sir, Dayanand Sagar University. His commitment towards academic excellence and institutional growth has always been a source of inspiration for us all. Again, even in his absence, he continues to support us and spread positivity. It is now my privilege to invite the respected Vice Chancellor, Dr. B.S. Satyanarayan Sir, whose dedication to higher education and institutional growth continues to inspire all of us to kindly come forward and occupy his seat on the dais. Welcome, sir. We are also deeply honored to welcome Nishant Sagar Sir, Joint Secretary, Dayanand Sagar Institutions, Mahatma Gandhi Vidyapeeth Trust, to the dais. Your dynamic leadership, vision, and continuous support towards academic excellence and innovation have been truly inspiring to the entire DSI community. Your gracious presence greatly enriches this occasion and motivates all of us gathered here today. Once again, warm welcome, sir. May I also now respectfully invite our esteemed Director of CD CIMER, Dr. A.C. Ashok Sir, whose leadership and commitment to academic advancement have been instrumental in the success of this institution, to kindly join the dignitaries on the dais. Thank you, sir. Now, I'd like to request the respected Dean and Principal of CD CIMER, Dr. Prashant Kumar M. Sir is an academician admired for his dedication towards medical education and research, to kindly take his place on the dais. Welcome, sir. I would also like to honor our very own HOD Department of Pharmacology, Dr. Shivamurthy N. Sir, the esteemed President of MPS and Professor Head of Department of Pharmacology, whose unwavering efforts and leadership continue to strengthen the scientific community, to kindly come forward and grace the dais.
May I request our Vice Principal, Dr. Srinivas Pai sir, the surgeon, to kindly take over the dais. Kindly give him the applause.
Next up, it is my privilege to invite Dr. Phulan Sharma Sir, General Secretary MPS, a distinguished academician and respected contributor to the Society's initiatives and growth, to kindly join us on the dais. Kindly come forward, sir. Now, I'd like to respectfully invite Dr. Melvin George, sir, Treasurer, MPS, an eminent scholar and distinguished expert in the field, to kindly grace the dais with his presence. Thank you so much. Once again, a warm welcome, and thank you so much for gracing us with your presence, dignitaries. Thank you. Moving forward, to invoke the blessings of Almighty for the successful conduct of our conference, let us begin with the invocation song and lighting of the lamp. I now like to request our esteemed dignitaries to kindly come forward for the ceremonial lighting of the lamp. Dignitaries, I request you to step forward. I would also like to invite Ms. Gayatri, Phase 3 student, to kindly come forward and to grace the stage with the invocation song.
वातापि गणपतिं भजेऽहं वातापि गणपतिं भजेऽहं वातापि गणपतिं भजेऽहं वारणास्यं वरप्रदं श्रीवातापि गणपतिं भजेऽहं वारणास्यं वरप्रदं श्रीवातापि गणपतिं भजेऽहम् भूतादिसंसेवितचरणं भूतादिसंसेवितचरणं भूतभौतिकप्रपञ्चभरणं वितरागिनं विनुतयोगिनं विश्वकारणं विघ्नवारणं वातापि गणपतिं भजेऽहं वारणास्यं वरप्रदं श्रीवातापि गणपतिं भजेऽहम् पुराकुम्भसम्भवमुनिवर प्रपूजितं त्रिकोणमध्यगतं मुरारी प्रमुखाद्युपासितं मूलाधारक्षेत्रस्थितं परादिचत्वारि वागात्मकं प्रणवस्वरूप वक्रतुण्डं निरतरं निटिलचन्द्रखण्डं निजवा मकरविधृते क्षुदण्डं कराम्बुजपाशबीजापूरं कलुषविदूरं भूताकारं हरादिगुरुगुहतोषितबिम्बं हंसध्वनिभूषितहेरम्बं वातापि गणपतिं भजे हम वारणास्यं वरप्रदं श्रीवातापि गणपतिं भजेऽहम्
Thank you. Thank you, Ms. Gayatri. Ladies and gentlemen, lighting of the lamp is not just a tradition, it is a symbol of wisdom and positivity. And may this auspicious lighting of the lamp continue to spread as much positivity as possible. With that, this was a formal welcome for the gathering, and it is now my privilege to welcome the President of MPS and Organizing Chairperson, Professor and Head of the Department of Pharmacology, Dr. Shivamurthy N. Sir, to deliver the welcome address. Over to you, sir.
Respected dignitaries, esteemed guests, colleagues, and dear friends, and dear students. A warm welcome to everyone. It gives me immense pleasure and deep emotional satisfaction to welcome you all to the MPSCON2026 Annual Conference of Medical Pharmacology Society, organized by the Department of Pharmacology and Physiology, Dr. Chandramma Dayanand Sagar Institute of Medical Education and Research. In brief, we call it as CD CIMER. In association with Medical Pharmacology Society. The conference is centered around the inspiring theme, Pharmacology 4.0, Smart Drugs, Smart Data, Smart Decisions. Today, as I stand before you as the organizing chairman, my heart is filled with gratitude, pride, emotion. What started nearly 10 years ago as a small academic initiative with a handful of passionate pharmacologists who are sitting next to me has today grown into a vibrant national and international academic movement. Seeing this hall filled with delegates who have traveled hundreds and even thousands of miles. We heard Miss Laila. She came all the way from UK. You know that there is a lot of tensions going on internationally, but still she could make it up to come all the way. Thank you so much for that. And also she is helping us with the sponsorship too. Seeing this hall filled with delegates who have traveled hundreds and even thousands of miles to be part of this scientific celebration is truly heartwarming. This year, MPSCON 2026 has crossed more than 500 participants. Please clap for all of you. This is the first time we have crossed 500, and it could not happen without your support. So this includes workshop and main delegates. This achievement belongs to every single person who supported us directly or indirectly. Both faculty members, office bearers, students, sponsors, institutions, collaborators, and well-wishers. I am truly honored to have your support, and I sincerely thank all of you for your trust, encouragement, and participation. At this moment, it is my proud privilege to welcome all the distinguished dignitaries on the dais and off the dais. It is our proud privilege to welcome our founders, Dr. D. Hemachandra Sagar and Dr. D. Premachandra Sagar in their absence, whose inspiration and institutional support made this conference possible. It is my proud privilege to warmly welcome our senior management representative, Mr. Nishant Sagar. So can I have the, shawl and trophy? So can I request Dr. Satyanarayan sir, Dr. Ashok sir, and Dr. Prashant sir to honor him. It is my proud privilege to warmly welcome Professor B.S. Satyanarayana sir, our Honorable Chancellor, Dayanand Sagar University. Sir, your commitment towards academic excellence, innovation, interdisciplinary learning, and the vision of India's AI-driven educational ecosystem continues to inspire all of us. We are deeply grateful to you for your continued encouragement and support towards MPSCON2026. Thank you so much, sir.
I would now like to request Dr. A.C. Ashok sir to kindly felicitate the respected Vice Chancellor of Dayanand Sagar University, Professor B.S. Satyanarayan sir.
Now, I would like to extend a warm welcome to our Registrar, Dr. Puttumadappa sir, in absence. So Dr. Puttumadappa sir is the Registrar, Dayanand Sagar University. So I would like to express my gratitude to him for his administrative guidance and support. Even in his absence, he is continuously supporting us, and we are truly honored to have your support, sir. And also, I would like to thank our General Secretary of Mahatma Gandhi Vidyapeeth Trust. In his absence, Mr. Galiswamy is always continuously supporting us, inspiring us to ensure that all the programs go uninterrupted. Now, it is my privilege to welcome Dr. A.C. Ashok sir. So we call him as Dynamic Director. Earlier we used to call him as Dynamic Dean. And now, since the same D is continued, we would like to introduce him as the Dynamic Director. And he is the one who was there from the day one when this institution is started. I have seen him walking every floor, every room, and ensuring that whatever the beautiful thing that you are seeing today, it is because of his direction, his vision, and ensuring that he always used to tell that if a medical college should be an international quality, it should look like C.D. Seimer. So thank you so much, sir, for your continued support and for your continued encouragement, and we are always honored to have your guidance. Thank you so much, sir.
I would like to request, I would like to request Dr. Prashant Kumar M. sir, our Vice Chancellor, to kindly, our Principal and Dean, to kindly felicitate our Director, Dr. A.C. Ashok sir.
Now, I would like to express my gratitude, and it is my proud privilege to welcome our very pleasant Dr. Prashant sir. He is always, he always welcomes us with a smile, and you go with any problem, he always supports us, and he always gives a very constructive suggestion so we are able to conduct this big conference. Thank you so much, sir, for your academic leadership, continued encouragement, and you have greatly strengthened this conference to make this big. Thank you so much, sir. So now,
May I now request Dr. A.C. Ashok sir to kindly facilitate our principal and Dean Prashant sir.
now I would like to welcome our new addition to our team as Vice Principal, Dr. Srinivas Pai sir. Sir, I have heard of you, your academic achievements, and thank you so much for taking the leadership. And under your leadership, we will be learning a lot. Thank you so much, sir. Welcome to the program.
May I now request Prashant Kumar sir to felicitate our Vice Principal sir.
Now, I would like to take privilege in welcoming my team members from MPS Society. I have Dr. Melvin George. He is our treasurer. So he is continuously supporting us in every activity what we are doing. And you can see such a grand program, and you understand what you mean by treasurer. So you really treasure MPS, and you have made us, all of us, to treasure the great moments. Thank you so much, Dr. Melvin, sir. Please.
I would like to request
Please
Dr.
accept our
Prashant
welcome
Kumar sir to kindly felicitate Dr. Melvin George sir.
Now again, one more important person who is always with me, with this society, and he conducted more than 10 workshops, including pharmacogenomics and cell biology and